This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 741, recorded on April 8th, 2021. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
That's right, Daniel. This is update number 57. And how are things going this week?
They are a little bit better. But what TWiV are you at? What TWiV are we up to, Vincent? Did you say there?
741.
741. Okay. I'm looking for the 747, because that's the big one with the upper deck.
Right, then after that, there's the 777, right? And then the 787. Yes. We'll go through all of those. Don't worry.
Okay. All right. Well, let me start with my quotation, and then I will give the update on where we are. So this is, be kind, for everyone you meet is fighting a hard battle. And this is actually from Philo of Alexandria, 20 BCE to 20 CE. So this goes back a ways, but I think maybe we need to remember. We've come out of this pandemic in a lot of ways worse, a lot of ways divided, hostile. Sometimes I feel like I'm in a Monty Python movie, when someone sees their neighbors, they run away because, this we've actually developed what I'm going to coin the fear of normal, FONO. A lot of us are pretty traumatized from this last year. So ideal if we can all start working together. We are on the same side relative to the virus. So my three quotations, as always: never miss an opportunity to vaccinate, never miss an opportunity to test, and never waste a vaccine dose. Let's get those vaccines into arms. The fridges and freezers do not need the vaccines. People do. Where are we right now? What's sort of the update? Worldwide, I don't often mention this, but worldwide, let's look, where are we looking, the world picture? Worldwide, the case numbers and deaths are rising. With over 500,000 new cases per day. It's probably more, but that's what we're hearing. Over 10,000 deaths per day. Again, probably higher. This is certainly not over. What about here in the U.S.? I like to think that the experience in Israel is encouraging. They're ahead of us. The experience in the UK is encouraging. They're also ahead of us. The U.S., hopefully we're going to be next in line, sort of a beacon of what happens with vaccinations. But we are still on this plateau here in the U.S., thanks mainly to a few states. I call you out, like everyone in Michigan, Florida, New York, New Jersey, and Pennsylvania. We're still seeing lots of cases, high positivity rates in these places. Now, Georgia, oddly enough, is not reporting a lot of cases. They're not in the top 10 in terms of cases, but they are in the top 3 in terms of daily deaths. So, I say that a little tongue in cheek, but there certainly are some issues with not doing enough tests around the country, particularly in certain places. So, you can't hide the deaths. I guess you probably could, as we learned. But when you see those deaths, it really suggests that we're not capturing all those cases. And I did want to point out, isn't the CDC in Georgia? So we need to be doing a better job of testing, tracking, and everything else. And across the U.S., we have less testing, but we still have the same number of new cases each day. So I'm not sure that, this is as low a plateau as people might think. The same number of people are in the hospital, sort of across the board, certainly here in New York since February. There are fewer deaths per day. It's odd that we're celebrating that we're under 1,000, that we're still seeing 600, 700, 800 a day. That's pretty high plateau. Things that have changed is the age of the patients in the hospital, and the age of those testing positive on average is decreased. That's something that's being reported. That's certainly something we're seeing in our, we still do a tremendous amount of testing here in the tri-state area at ProHealth and Optum Tri-State. So that's my update. But now let's get into children and COVID. This is always a hot topic. We've covered that full in-person learning can be done safely. And now we have guidance from the CDC. But I'm getting lots of questions about how do we actually guarantee that this is done safely and not just done. And this is sort of interesting. So I'm going to throw in, and this is sort of thrown out of phase order, but it's in the children topic. We got some updates about the multi-system inflammatory syndrome during the COVID-19 pandemic in children. So what I like to point out is that children certainly are at lower risk than adults, but they are not at no risk. So let's put some context here. So in JAMA Pediatrics, the article Trends in Geographic and Temporal Distribution of U.S. Children with Multi-System Inflammatory Syndrome during the COVID-19 Pandemic was published. This was a cross-sectional study of 1,733 patients with multi-system inflammatory syndrome in children, so the MIS-C. And the analysis included patients with illness onset from March 2020 to January 2021 that met the MIS-C case definition. Patients with MIS-C predominantly presented with gastrointestinal symptoms, such as abdominal pain, vomiting and diarrhea, as well as skin rash and conjunctival hyperemia. So that's a redness to the eyes, to the whites of the eyes. Most patients developed hypotension or shock, with about 60% overall being admitted to the intensive care unit. And I think I've mentioned that this went from early on being less to 50% to later on it being 80, 90%. So sort of evolving numbers. Myocarditis, so inflammation of the heart muscle, cardiac dysfunction, and coronary artery dilation. So these are the blood vessels that wrap around the heart actually dilating. That was reported in about a third of patients. Now, most MIS-C illness are believed to result from asymptomatic or mild COVID-19. I think sort of want to reinforce that asymptomatic or mild COVID-19 up front, with hyperinflammation coinciding with peak antibody production several weeks after that initial SARS-CoV-2 infections. So patients with MIS-C were reported to have significantly higher titers of the SARS-CoV-2 receptor binding domain IgG antibodies compared with other patients hospitalized with COVID-19. So just sort of an update. This is out there. We're getting more information on it. But let's talk a little bit about the school opening plans. I was getting a lot of texts and messages about one of the local school districts that is planning on opening, and they started laying out their guidelines. They're going to separate the desks by 3 feet. The children are going to be wearing masks at all times. They're actually going to have these plexiglass dividers, right? So I'm hearing all this. This sounds encouraging. Upgrading of the ventilation system. But then they had a very interesting quarantine outline. And what they were saying was that, okay, we're putting all these things in place, but if a child tests positive, anyone within 3 feet of them, so the desks within 3 of them, they will all be quarantined. And since this school is one where the children go to different classrooms, that one sort of index positive case will then affect, I guess you could do the math on this, right? Like 3 in front, 3 behind, and 1 on each side. So 8 kids from each class will be quarantined for, the required quarantine period. And some of the questions the parents were asking, well, if it's safe to be within 3 feet with all this mitigation, then why are these kids going into quarantine? If our kids are going to actually have exposures in school, and it's sort of a back and forth. And I think that one of the things that may be missing here for a lot of the schools is they're being asked to open, but they don't necessarily have the professional guidance to help them put the whole plan together. I think this has come up many times. If you do not have an exposure, you do not need to quarantine. And if you're setting up a school plan that's going to actually provide exposure opportunities for the children, that's not a great school opening plan. So, reach out if you don't have the expertise. If you don't know how to do this, and a lot of people don't have expertise. I mean, a superintendent, a principal, a teacher. I don't want to be the one, teaching your high schoolers or your middle schoolers. You probably don't want to be the one coming up with school reopening plans during a pandemic without some communication. So I throw that out there. I do think that we can open schools safely, but you have to have the understanding and the science to do this. And this ties directly into transmission. And today we're going to talk a lot about transmission. So much about COVID-19 has been controversial and even contentious. So remember my quotation. We're all in this together. The virus is the enemy, not your neighbor. And I guess I shouldn't be surprised. I still remember it was during my graduate training when, it almost came to fisticuffs. I was having a dispute with another one of the graduate students about whether or not NF-kappa B activation was essential for Th17 differentiation. Really? Really? that was enough to get like in a heated argument? Here, we're actually talking about something that affects people's lives. And, this is a scientific question. And I think we need to be level-headed when we discuss what do we know about this so that we can make appropriate decisions to protect everyone. I think one of the issues, I will say, the issue of transmission was complicated by terms of art. There are certain words that we use in science. There's certain words that we use even slightly differently in the clinical arena. Terms of art such as airborne, and there are common usage of these terms by the general public. So a lot of times people would ask that question, is this airborne? And I remember a wonderful article, it may not be airborne, but it's borne by the air, right? So there was a lot of confusion, like what is happening here? So in the Open Forum Infectious Disease Journal, the article SARS-CoV-2 infection among healthcare workers, despite the use of surgical masks and physical distancing, the role of airborne transmission, was published by a group out of Israel. So this was a case study where the authors described a single source outbreak of COVID-19 from an asymptomatic patient to 9 healthcare workers and room contacts in a general pediatric ward, despite meeting the current guidelines for PPE and the wearing of surgical masks. Now, due to confirmation bias, I actually worry about this article. I think it's going to be embraced by sort of both sides of this controversy, right? Back to sides again. So I'm going to take a moment here, and we're going to have to learn. It's going to be a little painful, but we're going to do a little vocabulary here. But I think this is critical. This is important. This is how we keep ourselves safe, and I think understanding these terms are important. So the first term, respiratory droplets. These are small drops or portions of liquid that are in the 5 to 10 micron range. These are expelled when a person coughs, sneezes, sings, or as we now know, I think is more generally appreciated, talking as well. People always think about this. If you're not coughing, you're not sneezing, if you're not sick, how are you spreading this? Just talking is creating these droplets. That's why a person can be pre-symptomatic and still create them. You do not need to be coughing, sneezing. Droplet nuclei or aerosols, right? Now we're talking about a term of art. These are small drops that are less than 5 microns. And due to their small size, they can actually remain airborne for extended periods of time and transmit over significant distances. Then we have fomites, and these are contaminated surfaces. So what about airborne transmission? Now, the CDC points out that this is a specialized use word in medicine and public health and is used to describe infections capable of being transmitted through exposure to infectious, pathogen-containing small droplets and particles suspended in the air over long distances that persist in the air for long times. And where are we with all this? I just showed you an article, oh my gosh, with an instance of airborne transmission despite masks. So as per the CDC, the principal mode by which people are infected with SARS-CoV-2, the virus that causes COVID-19, is through exposure to respiratory droplets carrying infectious virus. They do go on to say airborne transmission of SARS-CoV-2 can occur under special circumstances, and those were the special circumstances that we described. So what are those special circumstances? Enclosed spaces, right? We keep harping on indoor versus outdoor. Enclosed spaces within which an infectious person either exposed susceptible people at the same time or to which susceptible people were exposed shortly after the infectious person had left that space. So that indoor poor air circulation, prolonged exposure to respiratory particles. Remember, this is a continuum. There's no plexiglass sort of shield at this distinction between the different micron sizes. So shouting, singing, exercising, you're actually going to increase the concentration of suspended respiratory droplets in the airspace, so prolonged exposure. And then inadequate ventilation, which all this is all tied together, or poor handling. So you're allowing a buildup of suspended small respiratory droplets and particles. So that's your suburban home without good air exchanges. So I think that we can very clearly at this point say that the CDC, the WHO, and the science supports that the principal mode here is respiratory droplets. Airborne transmission is rare, but can happen in circumstances. And fomites, contact, I think the current CDC estimate is that maybe 1 in every 10,000th infection was due to surfaces. So just rethink all that bleach and Clorox and everything else. So on April 5th, so Monday, April 5th, the CDC published an updated science brief addressing fomite transmission. And this was titled SARS-CoV-2 and Surface Fomite Transmission for Indoor Community Environments. And I'm sorry to the makers of bleach, but this goes along the lines of what we've been discussing. But instead of focusing on the distinction in respiratory droplets and aerosols, it focuses on getting COVID-19, so getting that virus and developing COVID-19 from surfaces. And the summary statement: the principal mode by which people are infected with SARS-CoV-2 is through exposure to respiratory droplets. It is possible for people to be infected through contact with contaminated surfaces or objects, fomites, but the risk is generally considered to be low. So this doesn't mean we're walking around with unclean hands. I still want people to wash their hands. But I think there has been a lot of resources put into hygiene theater. And they actually conclude in the statement that in most situations, cleaning surfaces using soap or detergent and not requiring this disinfection is enough to reduce the risk. Testing. The Journal of Clinical Microbiology published a nice meta-analysis, performance of saliva, oropharyngeal swabs, and nasal swabs for SARS-CoV-2 molecular detection, a systematic review and meta-analysis. Now, for starters, what is a meta-analysis? So in the edited words of Mark Crislap of Persiflager's infectious disease PUSCAS fame, this is when you pile a whole bunch of studies on top of each other and they suddenly turn into gold. I think Mark will be turning over in his grave, even though he's still alive and just has decided to stop PUSCasing. So he's only died in a certain way. But this was really a high-level summary where they looked through. They found 1,253 unique citations. They then drilled down to identify 25 saliva studies, 11 nasal swabs, 6 oropharyngeal, and 4 oropharyngeal nasal swab studies. So from all the different sourcings, what they were using is nasopharyngeal swabs as the gold standard, and saying, if we do other methods, how much of the time are we able to pick that up? And so they basically came down with the nasal swabs were picking up about 82%. The oropharyngeal were picking up about 84%, and the saliva were picking up about 88% of those that were picked up with the nasopharyngeal swabs. They also reported a few things that I found interesting. They reported finding several studies that the unsupervised self-collected nasal swab specimens had higher percent positives compared to those collected by healthcare workers. So I was trying to analyze this. Is this that healthcare workers are too gentle? Is it that when no one's watching, people are willing to get a much better, deeper sample? So you turn away and tell them to go at it. I also thought it was interesting. A lot of times we have people hold a mask and they cough and they try to get up this deep throat saliva. And we tell them you can't eat, you can't drink, you can't brush your teeth. That really didn't seem to do much in terms of sensitivity. So maybe it's a little nicer. People can show up for their testing with brushed teeth and, having some adequate hydration. There were a number of limitations, though, I thought, in this study. And my big one, and I think all the listeners will guess at it, was where are the CT values? And I think we've learned over the last year that nasopharyngeal swabs are very sensitive, but sometimes maybe are they too sensitive to answer certain questions. So if saliva, for instance, is missing these low-level RNA PCR positives, weeks after the acute infection, do we really care? Is that really a limitation? Is this really relevant if we're testing to avoid transmission, such as might be done for certain sporting programs? Or now we know New York, working with Mount Sinai, is going to develop this large-scale saliva testing availability for opening large venue events. If those people have, a few thousand bits of RNA, am I concerned as someone going into a venue, particularly as a vaccinated person going into a venue, versus someone, who has a high positivity, such a large amount of RNA that's being picked up by antigen tests and all these others. So I think we have a lot of good testing options, and we just need to ask what question are we answering or asking when we do these tests. Active vaccination. There does seem to be some growing evidence that there may be an actual connection between the blood clotting and the platelet disorder and the AstraZeneca vaccine. I used a lot of qualifications in there. It's still appears that the incidence of this clotting and platelet complication is rare. And the risk of a COVID complication in most cases is significantly higher if you remain unvaccinated. But this is evolving. The Medicines and Healthcare Products Regulatory Agency, that's the MHRA, they regulate medicines, medicinal devices, blood components for transfusion in the UK. They reported 30 cases in 18 million vaccinated individuals. So we're looking at a complication rate of 1 in 600,000, but there have been 7 deaths. There may be an issue with the age skewing. This may be something that is clustered more in younger individuals. So we're actually certainly seeing some changes where there's a preferential use of this vaccine in older individuals and a preferential use of other vaccines in younger individuals. So this is an evolving story, and as we learn more, we're going to have to decide what to do here with this information. Just an update on the Pfizer EUA expansion, right? Let's get vaccines to younger individuals, or the option to have vaccines in younger, 12, 13, 14, 15. And as far as timing, right, we heard about the data. There is a required 15-day notice of intent to submit before the FDA performs their review. So Paul Offit, who's a member of the Vaccines and Related Biological Products Advisory Committee, just was saying the other day that so far the notice has not been given. So whether it's later this month, I think it's going to be May at the earliest that we see a potential EUA expansion down to our kids, 12, 13, 14, and 15. Passive vaccination, right? The monoclonals. This seems to be going much better as far as getting these off the shelves and to the patients. I think seeing the phase 3 data, all the help that we've gotten from a lot of individuals to get the word out has helped. I have to say, on our last tri-state urgent care call this week, the comment was that our Hoboken infusion center was basically getting fully booked. And there were all questions about how much capacity did we have for our in-home infusion program. So people are really getting out and they're getting these treatments. And I have to say, this is tremendous. When we see these individuals, the experience we have is they get the infusion and 36 hours later, they're really reporting sort of that Superman feeling. I actually spent some time recently over at one of the Catholic hospitals in our area, St. Francis Hospital, speaking with Stefan Mulbauer. He's the head of the ER there, just making sure we have everything firing as smoothly as we can on all cylinders. If I got that expression correct. But right, we have the ability with monoclonals to either go to outpatient infusion centers, to go to certain ERs, to go to certain infusion tents that are set up outside of ERs, and to get even in-home infusions. And this seems to all be going very smoothly with getting people access to the monoclonal cocktails. Some exciting developments before we move forward. Right now, as mentioned, that's great and all, but this is putting an IV in. It's 21 minutes we're allowed to, but a lot of centers are spending a full hour of the infusion plus a post-infusion observation time. Vir GSK, which is trying to get their product EUA, is also looking at expanding into an IM, an intramuscular preparation. So right now they have COMET-PEAK, which is an ongoing phase 2 trial. And they're really looking at, safety, viral kinetics, pharmacodynamics, doing this as an IM. But they're about to fire up COMET-TAIL, and this will be a phase 3 trial, which is going to be starting in the next month or so. And we'll be administering these IM products to high-risk adults, showing hopefully the same benefit for reducing hospitalizations and deaths. But you can imagine the improved access. You getting something like an EpiPen, where it can be just delivered from your local pharmacy, or maybe it's what's brought in by a infusion team or a home care team, and boom, just right into the muscle. We'll talk about whether or not you need to withdraw that plunger when you do that, and then going ahead with the treatment. Incubation post-exposure period. Remember, tests do not predict the future. I was on a call last night with a camp, and you got to keep saying that. I use the pregnancy test analogy. Once someone is exposed, there's a period of time when they can go on to become positive. If someone gets exposed, they immediately test, it's probably going to be negative, but that does not mean that they will not go on and become positive in the next 2 to 14 days. Once they get into that period of detectable viral replication, remember our passive monoclonals, our passive vaccination. So time for monoclonals and monitoring, no steroids, no antibiotics in that first week. If you do get into that early inflammatory phase, second week, if the oxygen saturations drop below 94, then you think of steroids, oxygen, anticoagulation, perhaps remdesivir. Most of these folks are not coming in with infections. That is a later stage issue. And we got a lot of information. I'm going to say close on this, but this is actually a big chunk. We're going to talk what we've learned about tail phase and long COVID. So in the BMJ, we saw the article Post-COVID Syndrome in Individuals Admitted to Hospital with COVID-19 Retrospective Cohort Study. So in this observational, retrospective, matched cohort study, they reported on the outcomes with a mean of 140 days for 47,780 individuals that had been admitted to the NHS hospitals in England for COVID-19 and had been discharged alive, right? So these are the individuals that got, almost 50,000 that got COVID, were in the hospital. Nearly 1/3 were readmitted, and more than 10% died during this follow-up. Those with COVID-19 were diagnosed with major adverse cardiovascular events, liver disease, kidney disease, diabetes after discharge. What were the rates? Respectively, 3, 2.8, 1.9, and 1.5 times more. So major cardiovascular, 3 times more likely. Liver disease, almost 3 times more likely. Kidney disease, twice as likely. Diabetes, 1.5 times more frequently than in the matched control group. This is a bit of an issue, right? I'm looking, forward to more data on this. But we also had another study, and I think this is getting a lot of attention. And this was in the Lancet Psychiatry journal, and this paper, 6-month neurological and psychiatric outcomes in 236,379 survivors of COVID-19, a retrospective cohort study using electronic health records. So this is really robust data, right? Almost 250,000 survivors. So this was a retrospective cohort study and a time to event analysis. And they were using data obtained from the TriNexS electronic health record. So over 81 million patients in this database. And I should say this database exists, right? I think we were painfully hearing of some early databases that were figments, but the primary cohort comprised 236,379 patients who had a COVID-19 diagnosis, and they had one matched control cohort, including patients diagnosed with influenza. Other matched cohorts included patients diagnosed with other respiratory tract infections during the same period. And they reported that the estimated incidence of a neurological or psychiatric diagnosis in the following 6 months was 33.6%. So a third of these survivors of COVID-19 hospitalization. If you were admitted to an ICU, the estimated incidence was almost 50%. It was 46.4. So this is huge. And now, what were these neurological diagnoses? Intracranial hemorrhage, ischemic stroke, Parkinson's disease, Guillain-Barré, nerve root, plexus disorders, myoneural junction and muscle disease, encephalitis, dementia, psychoses, mood and anxiety disorders, substance use disorders, and a lot of insomnia. Now, I have to say, this report is consistent with the work of some of my colleagues at UHG. They're, I think, a little frustrated because their study is still winding its way through peer review. But I had the opportunity earlier this week, the pleasure, I should say, of speaking with our pro-health neurology group. I always like to get, this is what we see in the literature, this is what the studies are showing, what are we seeing in our clinical practice? And so several of the neurologists were describing the challenges that we're seeing here in the tri-state area. Presentations consistent with small fiber neuropathies, with burning sensations, and a lot of issues with either new onset headaches or an escalation of headaches from intermittent to chronic. So unfortunately, a growing number of individuals who maybe had an intermittent vascular or migraine disorder, and now they're in constant pain, really challenging to treat these individuals. I think this will get a lot of attention because it's quite upsetting, I think, to not have your mind working, to be in constant pain, to be suffering. I think that's enough bad news, right? It's enough bad news. I'll throw a little bit of good news in here. And I think this is some perspective on the good news as well, right? We've heard a little bit, and I've shared a little bit about the potential benefit of vaccination on long COVID. And I've been seeing that. A lot of us who take care of a large cohort of patients who are never sick enough to get in the hospital, but continue to suffer with the brain fog, the fatigue, all these other disorders, we are seeing a large chunk of them report feeling better with vaccination. But I reached out to Lawrence Schulman. He's one of our pulmonologists. And, talking to him about what about people that were sick enough that now they have pulmonary scarring, now they have things that I just wouldn't really think a vaccination would reverse. In those individuals, a lot of our long-term care COVID or post-COVID recovery centers, where they're dealing people who had cardiac insults and pulmonary issues. A lot of this, I have to say, unfortunately, there is a subset of patients where this is not reversible by vaccination. So still encouraging all these individuals to get vaccinated, but it does sort of temper that optimism. There does appear to be certain patient populations that are more likely to benefit from vaccinations, but there are certain other individuals where a lot of the damage is done, the scarring is there. So I will close by saying thanks again for all the support we've had. This will be our final month, right? April, we are supporting the American Society of Tropical Medicine and Hygiene. And part of that support will be providing scholarships for early career women investigators from low-income parts of the world. So we're excited to do that. We're excited to allow them to attend the fall meeting, and then hopefully really give them a boost and do something about so much of the inequities that currently exist.
All right, time for a few emails for Daniel. You can send yours to daniel@microbe.tv. The first is from Alida in Canada, who's a nurse and is curious about, you're saying it is a must to aspirate before injecting an IM. In Canada, we have not done this for more than 20 years. I started nursing in 2000, and I have never aspirated. I've given thousands of vaccines and injections. CDC does not recommend aspiration. Just my thoughts.
No, they're more than just your thoughts. You're right. So what is this issue of aspiration, pulling back the plunger while doing an eye injection? So as I mentioned, this is hopefully I didn't say it's a must. Hopefully I said this is fairly standard, still common. Should it be? So what does the CDC say? What does the WHO say? What is the science? What is actually recommended and actually is not pulling back perhaps best practice? So let's go through this. Thank you for asking this question. So as per the CDC, aspiration before injection of vaccines or toxoids, so pulling back on the syringe plunger after needle insertion, but before injection is not necessary because no large blood vessels are present at the recommended injection sites, and a process that includes aspiration may be more painful for infants. They actually, I think your timing on when you graduated is appropriate. They reference a study back in the 90s, and the WHO does not recommend the plunger pull. So what does the science say? I have to say, based on what we know, the need for aspiration prior to administering an injection is dependent on certain factors, right? As a general rule, I'm going to say the science does not support that you need to pull back on the plunger. And there's ample evidence suggesting that. But what are the couple little caveats, right? It still is fairly standard. A lot of people do this. Is there harm? Well, as mentioned in the pediatric population, the original teaching was you held negative pressure for 5 seconds to make sure no blood would come up. That actually creates pain. That is painful. It is delaying. Some of us, and I think this is interesting, what about epinephrine? You say like, oh, this is epinephrine. If I got that into a blood vessel, oh my gosh, that could be quite different than an IM injection of epinephrine. Now let's all think about those EpiPens, right? Those EpiPens you basically put against your lateral thigh, you push a button and boom, out comes the needle and out comes the medicine. Things are a little different now, I have to say. I have seen people put injections in the deltoid bursa. I have seen people completely miss the muscle and put it in the fat. Probably the pulling back on the plunger is probably a small issue. What are the big issues? Getting that needle into the muscle using a 1-inch needle, so you actually get through whatever subcutaneous tissue and into it. If you're going to do IV, you definitely, well, I'm going to use the word definitely. You do want to make sure you're in the vessel because a lot of our medicines, if they're infiltrating, can actually be caustic and cause tissue damage. But yeah, if you're going to put it into a muscle and you know what you're doing and you're actually in the muscle, do you really need to pull back? No. Is it better not to pull back? Yeah, probably actually. I think best practice would be no. If you're going to give the shots in the deltoid, put it in the deltoid, not in the bursa, not in the chubby part of the arm. If you're thinking about doing a buttock shot, actually consider moving that to lateral thigh.
We actually got a lot of emails about that, and they were divided between we don't do it and we do it. It was very interesting. So it's one of those situations.
Well, it's come up, I think, Vincent, because the whole AstraZeneca issue.
Yeah.
And one of the theories they have there is that maybe, younger people, better, vascularized muscle, maybe there are large enough vessels that you're getting it in there. It's good to have the science and the current recommendations. We did so far this week, 213 vaccinations in my office. We're doing another 100 tomorrow afternoon into the evening. Have I been pulling back on that plunger every time? No. Have I pulled back ever? No. So I'll fess up.
Okay. Deepa writes, I have been advised by my most excellent rheumatologist to skip 2 doses of methotrexate after taking any vaccine, including the one for SARS-CoV-2, based on the attached publication. This is the first study I'm aware of that carefully evaluated the immune response to flu vaccine in RA patients. They randomized to 2 cohorts, one that skipped 2 doses of methotrexate, one that did not. There is quite a remarkable and significant difference in the antibody response elicited in favor of skipping methotrexate. Key finding, methotrexate discontinuation for 2 weeks after vaccination significantly increases immunogenicity of a seasonal influenza vaccine in patients with rheumatoid arthritis who had been on a stable dose of methotrexate without significantly increasing risk of disease activity. I hope this is helpful to you, your patients, and listeners of the podcast. Not many people are aware of this study. We need more studies like this.
No, this is great. So thank you. Actually, Deepa, we do need more studies like this, and there's no reason that we can't be getting them, right? We are currently vaccinating, well, billions of people by the time we're done here. And this is the time. And I know a lot of scientists have talked about we need a rapid review, rapid ability to fire up these studies. And if you think about it, right, these are studies that are minimal harm. They're kind of observational studies. Rheumatologists, physicians who are using these medications are trying to space these out. Some people, sort of almost practice preference, might be only a week. Some people don't do this. Other people are getting this 2-week. This is data, I think, that would be very valuable in helping us just in immunizations across the board, right? We do not only influenza vaccines, hopefully every year, but now we do COVID vaccines. We have a lot of vaccines. So having really good science-based guidance here would be tremendous.
All right, one more from Mary Ann, who writes, I got my first dose of Pfizer March 23rd. At the time I signed up, Walgreens had us schedule the second dose 4 weeks out, and my next is scheduled 28 days. And she found out yesterday by the Times that Walgreens had taken it upon themselves to schedule these second doses at their convenience rather than at the tested interval, which should be 3 weeks, 21 days. And Marianne goes on to expressing her displeasure with Walgreens and wants to know, any advice? Should I be looking at a booster sooner than later? Should I be asking my doctor for antibody testing? What can I do? I was looking forward to getting out of my house again. Now I feel unsure. I figure I'll be wearing a mask forever.
Okay. So don't be so upset. Yeah, this was interesting, right? Walgreens decided that it would be easier for them, for their scheduling system, to just do 4 weeks between shots and just didn't care whether it was Pfizer or Moderna, which is interesting too, right? Because they're shipping those second doses out and then they're sitting on a shelf somewhere for like an extra week, right? Not in people's arms. And Walgreens was basically taken to task when this became public and told that is not what we recommend. You need to be giving those second doses, 21 days or sort of 4 days either side of those 21 days, not waiting till 28 days, unless, as we say, extraordinary circumstances. So, go ahead, get that second dose when you can get it. Do I think scientifically it makes a difference whether you're getting it at 21 days or 28? In a lot of ways, I compare Moderna and Pfizer to Coca-Cola in a can versus Coca-Cola in a bottle. You're getting the same mRNA. The packaging's a little bit different. The size is a little bit different, but the outcome, it's going to quench your thirst. It's going to protect you from COVID quite well. So yeah, don't feel like Walgreens creating this difficulty is going to mean that you're going to be less protected at the end of the day.
So Marianne says, thank you and the whole TWiV team for being a calm place to find accurate information. You guys get an A++. Walgreens gets an F-. Okay. And on that note, that is COVID-19 clinical update number 57 with Dr. Daniel Griffin. Thank you, Daniel.
All right. Thank you so much. And everyone, be safe.